file. There we go. Hypersensitivities. These are conditions that are characterized by over the board response from the immune system. There are 4 types: immediate hypersensitivities and delayed hypersensitivities. They are mediated by different mechanisms. And the first one that some of you are familiar with is an allergy. It's type 1 immediate hypersensitivity. So here's the thing. Allergy, we call it an allergy because your immune system produces the response to the antigen it is not supposed to respond to. When you are exposed to the allergen first time, okay, allergen somehow gets into the lymphatic system and it's presented by the antigen presenting cells to TH cells. So T helpers stimulate B cells to make antibodies. Those are not regular antibodies. Those are IgE, immunoglobulin E. It's a first exposure, okay? And those IgE, those antibody molecules, bind to basophils and mast cells in your tissues. And first exposure is done. Nothing happens. You don't have allergy yet. So now you have a bunch of mast cells in the tissues, like connective tissue, with IgEs bound sitting on the surface. And then you encounter the same antigen again. Second encounter, when antigen binds to immunoglobulin E already on the surface of basophils and mast cells, leads to basophil and mast cell degranulation. Does that make sense? Granules in mast cells contain histamine. Histamine is released in the tissues. You have itchy eyes, you have runny nose, you have, I don't know, hay fever, you have itchy skin, and so on and so forth. Hives. Does that make sense? So first exposure doesn't produce the actual symptoms. It's the second exposure that produces it. Okay? Is that mechanism clear? Do you understand what I'm trying to say here? Now, before we move to type 2, okay, it thinks I just prefer not to touch. In type 1 hypersensitivity right here, if only cells in the tissues degranulate in the, like, where you are exposed to the antigen, like nose and throat, you have itchiness. For instance, I have very mild allergy to apples, practically all apples, so it manifests as itching in the mouth. Okay, like my lips and my throat becomes scratchy, and then it goes away. Okay, I'm allergic to cats. Portal of entry for allergen is my nose and my throat, so I develop runny nose. Of course, I rub my eyes. Itchy eyes, watery eyes, and then I develop usually asthma sometimes. Okay. But what if degranulation becomes systemic? What if all mast cells and basophils degranulate and release histamine everywhere, including circulation? You have anaphylaxis. Histamine leads to the dilation of blood vessels, typical inflammatory response. This time blood vessels dilate in all body, right? That leads to the quick drop in blood pressure, and that's anaphylactic shock. Okay. Constriction of smooth muscles in airways causes the obstruction of airways and asphyxia. And then we, of course, do EpiPen. Can you treat allergy? Yes, yeah, and you take antihistamines. Lousy way, but usually you better take it before, okay? Before you know, like if I know that I'm going to the house with a cat, I take Zyrtec or whatever I have 1-2 hours before I get there. So it's in the system, and even if histamine gets into the bloodstream, it doesn't interact with the receptors. How? There is. Exactly. It is called desensitization. They didn't knock down the peanut allergy completely, but in people who had allergy at the level like, I don't know, Erin eats peanuts and I'm dying of anaphylaxis right here, it gets to the point when kids can't be at the same table. So if somebody eats peanut butter sandwich, kid with an allergy doesn't die. Okay, it doesn't have an outbreak. So they're still allergic. If they will eat it, they will die, but, you know, they become much more tolerant, yes. Yes. That is called desensitization. That is a therapy. I saw this. I'm allergic to cats, and I saw this like a therapy. They introduce allergens from cats to you in a really small amounts over like span of 2 years. I said, screw that. I'm going to go and buy some Zyrtec. Just simple. Okay. And we're not going to get a cat. That's it. I'm fine with that. Okay. But now I think they have a more rapid courses. So yeah, you can be treated. You can be treated so allergy will go away. Of course, in severe cases, severe allergy, steroids will help. But those are immunosuppressants. You don't want to be on them for too long. Okay. Does that make sense? Yes. Fantastic question. I have no idea. I know a good friend of ours, every time she goes away on a vacation and leaves her cats like for a month, she comes back, she's allergic for 2 weeks, and then she gets back to normal. Yes. But the thing is, yeah, my wife, a couple of times, she said, what if we get a cat and we will suffer for 2-3 weeks, and then you'll be fine? And I told her it's either cat or me. I don't want to suffer for 3 weeks. I suffer enough. And I have just runny nose and watery eyes. My son develops real full-blown asthma every time he's around cats if he's not on antihistamine. So no, I don't want him to have asthma for 3 weeks. It sounds like a lousy way of life. Yes, go ahead, go ahead, go ahead. Mm-hmm. Mm-hmm. It probably, you're probably still going to get desensitized because it kind of counters the symptoms, not the core, right? Antibodies will still bind to the mast cells and lead to the degranulation. But antihistamines, they have some side effects. And modern ones don't really put you to sleep, but they have profound effect on the digestive system. They inhibit histamine signaling in the stomach, leading to the decreased acid production and indigestion in the long-term perspective. Okay, good. So, and it's technically an immunosuppression. I don't want to be, because histamine, other than allergy, it also plays important roles in inflammation. I don't want to be immunosuppressed for such a long time. Okay. Now, type 2 hypersensitivity. Now, this one is mediated by immunoglobulin G that you already have, and that's your blood types. Okay. Let's quickly review. So, immunoglobulins, recognized antigens that shouldn't be there and they shouldn't recognize. So, red blood cells on their surface may have antigen A, which is carbohydrate. It's also called agglutinogen. Antigen B, both of them, or none. So blood types, respectively, called type A, B, AB, and O. Does that make sense? These agglutinogens are recognized by the immunoglobulins present in the plasma. These immunoglobulins are called agglutinins. Okay? Obviously, people who have agglutinogen A do not have antibodies against it, but they do have antibodies against B. People who have agglutinogen B do not have antibodies against it, but have antibodies against A. People who have both AB on the surface of the red blood cells have no antibodies, and people who have nothing on the surface have both anti-A and anti-B. So when you mix anti-A and anti-B serum with the type O, for example, you will see agglutination of the red blood cells. Does that make sense? Because both antibodies will bind to red blood cells and clump them together. That's your agglutination picture. Does that make sense? So when blood is transfused, blood transfusions, attempts of blood transfusions, they go back in the 19th century. They tried to transfuse horse blood, monkey blood. Never worked, of course. And then from random people until Karl Landsteiner discovered these blood groups. Okay. The most critical part of the blood that is transfused is red blood cells. So we're talking about most of the red blood cells. So what if you take red blood cells of a person with type O and put it in the person with type B? Is there going to be a reaction? No, because you put red blood cells, not plasma, and those red blood cells have no antigens. So type O, how do we call them? Universal donor. What about type AB? The universal recipients, because they do not have antibodies. No matter which red blood cells they receive, there's no reaction. Are we clear on that? I will ask you about, like, what if you put this to this? What's going to happen? And you tell me. Okay? Or which of these, transfusions is safe? And I give you a list and you tell me. Does that make sense? Consequences: red blood cells agglutinate, they clump, blood flow is impaired, they also start to lyse, hemoglobin is released, and it's going to kill your kidneys. Okay? Does that make sense? Rhesus factor, we're going to get to this picture. Rhesus factor was discovered on the red blood cells of Rhesus macaques. Later, it was found on human red blood cells. It's a different one. It's called Rhesus agglutinogen or D antigen. Unlike AB, ABO grouping, we do not have pre-existing antibodies to D antigen. So if you are Rhesus positive, or if you are Rhesus negative, it doesn't matter. You have no antibodies against Rhesus. Does that make sense? But if I am D negative and I receive D positive blood, I am going to form the antibodies. Does that make sense? Because this D antigen comes from somebody else. So far, are we clear? That brings us to the Rhesus conflict. The situation when mother is D negative and the fetus is D positive. Mother blood and fetal blood, are they separated during pregnancy? Physically? Yes, completely, by placenta. There's no contact between blood. There's diffusion, of course, but there's no physical contact. So, D positive or Rhesus positive red blood cells of a fetus They never get in contact with mother's immune system, except for one moment during delivery, during the detachment of placenta. It's a short moment when fetal blood and mother's blood mix. So mother becomes exposed to Rhesus positive red blood cells. And remember, mother is Rhesus negative. In response to baby's red blood cells, Rhesus positive red blood cells, mom develops antibodies. Is baby harmed? No. Baby's fine. Baby's delivered. Baby's okay. But mother now has antibodies to the antigen. And then mother gets pregnant again. And she's D negative and baby's D positive. She already has antibodies. Where do they go? Cross placenta into a baby and attack baby's red blood cells. This is called erythroblastosis fetalis, or I forgot not the fancy name. Thank you. Hemolytic disease of the newborns. Yes. Pretty bad. Transfusions, hypoxia of the fetus, and vascular problems. A lot of problems. Okay. So, how can you prevent rhesus conflict? If you say you are rhesus negative female, and you're about to conceive a child. Wait. Well, first of all, if you date someone, you should ask, what's your blood group? And if it's positive and you're negative, say, screw it. Forget it. I'm kidding. But it's not a bad idea to ask. Because if you are D negative and your fiance is D negative, you're fine. Your baby's going to be D negative. Nothing to worry about. If you have difference, then you should think, okay? Second option, not to have kids. Okay. Again, not always works. So third option is ROGAM, antibodies. These antibodies that mother receives, they actually recognize the antigen. And it kind of sounds counterintuitive, doesn't it? I mean, you put antibodies in the mother, you inject them, antibodies that mother could later produce. So how does that work? ROGAM shot circulates, and when there is an exposure, it recognizes baby's D positive red blood cells and binds to them. Does that make sense? So, what about mother's immune system? Can it see them now? No, it masks them. That makes it kind of puts a protective invisibility cloak. So mother is not exposed. The immune system doesn't recognize baby's red blood cells because ROGAM antibodies coat them. Does that make sense? And it can be done during each rhesus conflict pregnancy. And it works just perfect. Does that make sense? So far, yes, go ahead. That's good that everything worked out well in the end. I cannot even imagine what it's like to realize that it may not be your child. So understand type 1, type 2 hypersensitivities, transfusion reactions in rhesus conflict, the mechanisms. Okay, blood groups and mechanisms. Type 3. immune complexes. That's a true autoimmune disease. Okay. Antibodies that are produced by your B cells, plasma cells, should I say, plasma cells, recognize the tissues that they must not recognize. For instance, they recognize components of the basement membrane. That's basement membrane, okay? Components of the basement membrane. What does basement membrane separate? Two types of tissues. Connective and epithelial, yes. So it separates connective and epithelial tissue. Okay. And those antibodies get into the basement membrane at the border between them and bind there. Antibodies, per se, are they going to do anything to the basement membrane? Listen. Antibodies. Can they lyse or kill cells? By themselves? That's a simple question. No, they cannot. They just tag. But the problem is that these immune complexes of proteins of basement membrane and antibodies are recognized by neutrophils. Now, neutrophils start to migrate into the areas with immune complexes and start to destroy them, because that's what they're supposed to do. Immune complex, if something is tagged by antibodies, it must be destroyed, right? Does that make sense? So you get constant infiltration of neutrophils and destruction of the basement membrane. And your epithelium starts to suffer. Does that make sense? Epithelium starts to die. Mechanism like that is underlying mechanism for several autoimmune diseases. For example, systemic lupus erythematosus, systemic autoimmune disease, manifests as the thrombosis and vascular leakage, because epithelium in the simple squamous epithelium in the blood cells is hurting. Kidney problems, skin problems, okay, bleeding into the skin or slowing skin, endocarditis, inflammation of the endocardium, the valves, and so on, joint problems. Same goes for rheumatoid arthritis, for instance. Rheumatoid arthritis has several mechanisms. It's type 3 and 4 for sure. So it's type 3 and type 4 hypersensitivity. So in rheumatoid arthritis, antibodies migrate into the synovial membrane and target synovial membrane for macrophages. Macrophages migrate into the joints, start to destroy synovial membrane, produce inflammatory cytokines, which increases blood flow to the joint, causes joint swelling. So you have typical arthritic joint. Swollen, synovial membrane is gone, synovial fluid is not produced as well as it should. Okay, does that make sense? That's your mechanism. Yes. There are two mechanisms. Let's do type 4, and I will talk about MS. As much as I know, I'm not an expert at all. Now, delayed hypersensitivity mediated by T cells. Two examples: the reaction to different plant poisons like poison ivy, and TB test. MS as well, but that's entire disease. So what happens is, when you are first exposed to the antigen, okay, your immune system forms specific T cells, memory T cells. When you are exposed to the same antigen again, the helper cells, they activate macrophages. CD8 cells are activated. They come from the memory pool themselves. So you have macrophages and cytotoxic lymphocytes migrating to the site where the antigen is, which means, let's get back to the, what you might call it, poison ivy. When you first touch it, usually do not produce any reaction. You don't even know that. Then when you do it second time, if your immune system formed the response, not every person will have it, but if your immune system has those memory cells, they will migrate to the site which was affected by the poison, and they will start to destroy the cells with a poison on them. Does that make sense? And you got this massive inflammation and necrosis. TB test. If you were ever exposed to tuberculosis antigen, either through the vaccination or an actual infection, your immune system at that time produced T cells. That's a memory pool, okay? Memory T cells. When you get for the TB test, what do they take? Where does the shot go? Huh? More detailed. Nope, not subcutaneous. Intradermal. It goes, doesn't go subcutaneous, it goes intradermal, into the skin. Because in the stratum spinosum of the skin, there's a cell from AP1, stratum spinosum, immune cell. Langerhans cell. Very good. Langerhans cell. It recognizes that antigen and starts to present it to T cells. Okay? T cells, CTLs will start to proliferate and will migrate to the site. With injection, same goes for macrophages, and you have a little bubble, right? Only if you had the exposure. If you did not, there will be no inflammation, there will be no reaction. Does that make sense? Okay. So that's your CD4, fourth type. How MS works. There is for some reason, people with multiple sclerosis produce a set of T cells that attack myelin, that covers nerves. And I think it's exclusively oligodendrocytes, not Schwann cells, so it's CNS. So it starts to destroy myelin sheath. Without myelin sheath, the signal transduction suffers, to say the least. It slows down. Neurons also start to die without myelin sheath. And that's it. Depending on which part of the brain is affected, it can manifest from things like dementia. If it's, what's the word? Okay, capabilities to recognize. Cognitive, if that's the cognitive part of the brain, or we have we know family, wife, she suffers from MS, it's a progressive paralysis. Okay. It started with her lower limbs, so upper body works fine, lower limbs gone. Okay. And it's a progressive disease, so you had another question, or did I answer? Yeah, and the only way to treat it is a number of immunosuppressants. The most advanced now, they suppress, as far as I know, they suppress T cell proliferation, okay, and differentiation. So, of course, it puts people at the high risk of infections, but it slows down the disease. Okay, we really have good drugs about it. Did I answer? I think type 3 hypersensitivity, which is immune complex mediated, is also involved, but I definitely know that T cells do. They are involved. Antibodies, immune complexes, I cannot kind of stand up and say that's true. I need to look it up. I think I saw it too. Transplantation. We have 4 types of transplants. You have to know them all. Autotransplantation, when your tissues go into your cell. Examples: skin grafts during plastic surgeries, cosmetic surgeries. Burns, yes. I didn't see a lot of burns before and after, but we had a doctor who presented his work on head and neck cancers, and when people have head and neck cancers, large portions of head or neck have to be removed. It's not that funny, honestly. It's mostly throat, jaw, mouth, so they may have like half of it, their lower jaw removed, and they do the cosmetic reconstruction of the jaw, which is doable, and then they have to transplant the skin to cover it. There's no immunological rejection. There's a problem though with keeping the graft alive for the several hours when they transfer it from, say, the buttock to the face. It's really big, but this problem lies in the vascular biology, not in immunology. Isograft is the transplantation between identical twins. So if anyone has an identical twin, it would be a good time to secure them now in the basement, feed them properly, uses potential donor organs. Into sort of that ballpark goes the stem cell therapy. Since now we know how to turn back time in cells, do the so-called inducible pluripotent stem cells, which means you take any cell from the human body, like fibroblast, you treat it with a cocktail of cytokines, and it becomes less specialized, like Curious Case of Benjamin Button. Okay, so it becomes stem cell again, and then you can use this stem cell to grow, I don't know, a liver or a muscle or something else. So it's almost, so if we would be able to grow, like you give your cells, they turn them back in time, and then they grow you a new liver and you can drink again. Allograft. Anything between 2 people who are not identical twin. Most of the transplants are allografts. Okay. And xenograft between species. It's not frequent. You can do xenograft of, let's say, cardiac valves from pig to human. So tissue that is not very immunologically reactive. Okay. So now there are 2 aspects, 2 versions of rejection. So in case of transplantation of a solid organ like liver or kidney, what about MHC on the transplanted organ? What does it show? Foreign antigens, right? Presents antigens. Antigens that are foreign. So your immune system does not recognize them as self, it recognizes them as foreign, and antigen-presenting cells will process those antigens inevitably. There will be some death. Your dendritic cells will take up portions of the transplant. They will present it to your immune system, and your immune system will mount the response. Does that make sense? That's the typical picture of rejection. T cells will start to attack the transplant, and unless you treat it, the transplant will be a toast. It's still a problem. People who have transplanted organs have to take immunosuppressants. There are approaches to, stem cells There are some treatments, to tweak something, MHC, some stuff, but still the main treatment for rejection is immunosuppression. That makes sense. Now, what if somebody has leukemia? What is the treatment for leukemia? Bone marrow transplant. Let's do it step by step. Before you transplant an organ, bone marrow is an organ, what do you have to do with an old one? Yeah, you have to ditch it, right? I mean, you don't just put second liver next to the first one, right? Same goes for bone marrow. You have to ditch it. How do you kill bone marrow? Huh? Chemo, you can do radiation, but the point is that you get rid of as many bone marrow cells as humanly possible. What happens to your blood cells at the point when you killed your bone marrow? Yeah, you have nothing to make your blood cells at, right? So you transplant new bone marrow. Okay, what does it start to do? What does it make? Bone marrow. Blood cells. New blood cells. Which blood cells do you know? Red blood cells. They're boring. What else? White blood cells. What's the white blood cell function? Immunity. So white blood cells that came from somebody else, they get into the bloodstream lymphatic system and they, holy crap, we're surrounded by foreign antigens. Let's kill them. This is called graft versus host disease. It's a side effect of bone marrow transplantation. One of the first recorded examples was in Soviet Union. 2 engineers went into the gamma ray cannon. It's like a chamber where surgical instruments are sterilized. So chamber is irradiated with gamma rays. So the cannon stopped working. They went to fix it. They went inside the chamber, fixed it. It turns out nobody switched it off. So when they fixed it, they were exposed to killing doses of radiation. And they were horribly sick. Their bone marrow was gone completely. And doctors decided, well, we'll just transplant it. And they took bone marrow from somebody else and put it in those guys, and those guys miraculously recovered. They were absolutely fine until a couple of months post-transplantation. It was like 70s. A couple of months post-transplantation, they had massive systemic organ failure. So everything, new immune system started to kill everything, and they died from massive organ failure. So now that's why we do the match, because the better the match, the less chances of rejection. And it's actually great for bone marrow because if you are, I'm on the bank, I'm in the database, potential donors. So if there's somebody who I can match with, I would be happy to donate my bone marrow. Okay, because that's how we look. We have someone who needs it, and then we see there's a match. For solid organs, there was a case when a patient who required think heart transplantation in Britain, the match for the heart was found in the US. And it was a military jet that flew from US to Britain to bring heart. So it's fast enough. Not regular military jet, just direct shipment. So it's kind of matching. If the good donor comes up, that's good. Now, the last thing that we're going to talk before we turn to the lab is immunodeficiencies. So we were talking about hyperactive immune system. This is the example of immune system that's not active. Immunodeficiencies can be congenital or acquired. Let's get the acquired out of the way. So acquired immunodeficiencies are the ones that you get during your lifetime, the ones that you're not born with. We clear? Like cancer. That's immunodeficiency. Especially leukemia. That's typical immunodeficiency. AIDS. Now you have to understand that AIDS, although this word is strongly associated with HIV, we say HIV causes AIDS. AIDS is like cough, like diarrhea. It's a syndrome, okay? Acquired immunodeficiency. Does that make sense? It turns out that that specific set of symptoms and signs that we observe in AIDS is caused by HIV. Now, a little bit of a heads up, HIV infects, does anyone know which cells? T helper, CD4 cells. So if CD4 cells are gone, what else is suffering? No antibodies, B cells. CD8 cells are not activated properly, and macrophages. So you get rid of one subset of T cells, and suddenly your entire immune system goes into the dumpster. Does that make sense? That's acquired immunodeficiency. Another great example of acquired immunodeficiency that we talked about it. Measles. Measles virus replicates in the B cells and kills them, and they do not come back for about 6 months after infection. All that time you're immunosuppressed, you're immunodeficient. Okay, and as I mentioned, measles vaccination does not only protect you against measles, it also protects you against secondary infections associated with measles. Generally, anything that reduces your immunity is immunosuppression, okay? Acquired immunodeficiency. Severe influenza will cause acquired, it's going to be transient, so for some time, but acquired immunodeficiency. Make sense? Congenital. As far as I know, so can be some mutations in the innate immunity. I mentioned before the girl who acquired influenza and developed really severe form of it. Turns out she has a mutation in IRF3 gene, which is part of interferon pathway, blah, 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 blah. Otherwise, she looks healthy, okay? I don't know about people, but there are mice you can make. There are mouse strains that do not respond to interferon. They don't have receptors for interferon. They live right there. You can house them in the regular conditions. I mean, if you infect them, that's a different story. They're going to develop much more severe disease, but that's fine. So people may have mutations in different components of innate immunity, but since it consists of so many parts, like interferon and complement and white blood cells, it is never gone completely. Do you understand what I'm trying to say? It is there. You may have mutations, but it doesn't cause extremely severe problems. So it's adaptive deficiencies that can be really problematic. So which two branches of adaptive response we know? T cells and B cells, cellular and humoral. So you can lack B cells, functionally, you can lack T cells, you can lack both, right? And you lack humoral response. This is called A-gamma globulinemia, okay? B cells do not mature in the bone marrow. There are no mature B cells. There is no antibody production. Does that make sense? People have no antibodies whatsoever. In the milder version of that disease, B cells do mature, but there is a mutation in adenosine deaminase gene, which leads to low antibody levels. This is hypogammaglobulinemia. Okay? People with agammaglobulinemia or hypogammaglobulinemia, it's a mouthful, they receive transfusions usually. They may just, sometimes they receive sort of a whole slew of immunoglobulin fraction of the plasma from other people. Okay? Just for the increased protection. So it's people with this disease, they live. Okay? It's not healthy life, but they can live for a fairly long amount of time. Okay? T-cell deficiency is called DiGeorge syndrome. That's when T cells do not mature in the thymus. Okay? Again, deficiency in adenosine deaminase severely decreases. That's milder version of DiGeorge syndrome. Okay? Severely decreases the efficiency of T cells. Now, people with DiGeorge, they can survive, they can live, although they, of course, are very prone to various types of infections, especially virus infections and parasitic fungal infections. Okay? Some people do not have both. This is called severe combined immunodeficiency. People who lack both B and T cells. And you may have heard, also called SCID, you may have heard about boy in a bubble. It's not very frequent mutation. So I know, briefly, I can tell you the story about two kids. So one, they both born with that condition. One lived in practically a bubble, so it was sort of a giant biological safety hood with the sterile air, positive pressure, so everything was blown out of his enclosure. People who got in contact with him were wearing protective gloves and masks and gowns and everything, and his food got sterilized. It was pretty much, he lived in a sterile environment. But at, I think at the age of 14 or something like that, he actually moved out from the hospital. He started to receive blood transfusions, regular blood transfusions, and that's what provided immunity for him. And he died at the age of about 30. Guess from what? He died from kidney failure. Because with every blood transfusion, you have minute transfusion reaction. Minute amount of hemolysis, which affects your kidneys. Over time, these effects accumulate and kidneys fail. Another example was more tragic. The boy, how can you treat the condition like that? How can you treat when cells, white blood cells, lymphocytes are incompetent? What do you have to transplant? Where are they made? White blood cells. Bone marrow, so you have to transplant the bone marrow, put the fresh one, okay? So this kid, turns out that his sister was a good match. They decided to transplant bone marrow from this kid's sister to him, did everything, they transplanted the bone marrow, and what the recipient starts to take, what types of drugs? Immunosuppressants. His sister had the latent Epstein-Barr virus infection, which was latent in the bone marrow cells. So when he received the transplant, started to take immunosuppressants, Epstein-Barr virus had a field day. And he died of the massive systemic Epstein-Barr virus infection, only because he was severely immunosuppressed. And she wasn't tested for it. Now that family had another child. They wanted a son. The second son had same disease and died at the age of 6 months. The doctor said, stopped trying, but they tried again, and the third child was healthy. So now, in that story that I told you, first of all, you may have noticed that two boys, and well, 3 boys actually, counting that 6-month-old, 3 boys had this disease and died, but eventually a boy was healthy. And the girl, one only daughter, I never mentioned that she was somehow sick. What does it tell you about the inheritance of that gene, inheritance of that disease? But it's recessive. So the boys were, 3 of them were sick and then 1 was not. So it may or may not be, and girls don't get sick. So it's sex-linked recessive. Does that make sense? So women are carriers. So if a carrier woman produces an offspring of a male sex, okay, gives birth to a son, that sounded awkward. If a carrier woman gives birth to a son, then son may have chances, 50% chances to become sick. Does that make sense? That's it for the